Margie, thank you for coming in today.
Oh, thank you for seeing me. I appreciate it.
Your learning objectives for mastering the examination of the female genitalia are to describe the pelvic anatomy, to elicit common symptoms related to menarche, menstruation, menopause, and postmenopausal bleeding, vulvovaginal symptoms, sexual orientation and sexual response, pelvic pain, and sexually transmitted infections, to observe current screening guidelines for cervical cancer and sexually transmitted infections, to position the patient and prepare carefully for the pelvic examination, to examine the external genitalia, and perform a speculum and bimanual examination of the internal genitalia, and to collect the Papa-Nicolau smear. Questions about common or concerning symptoms relating to the female genitalia, anus, and rectum will give you an opportunity to explore the patient's concerns and attitudes about her body. These include menarche, menstruation, menopause, and postmenopausal bleeding, pregnancy, vulvovaginal symptoms such as vaginal discharge and local itching, sexual orientation and sexual response, pelvic pain, acute and chronic, and sexually transmitted infections. For the menstrual history, establish the start of the last menstrual period and any pain with menses. Depending on the patient's age, the patient may ask about premenstrual syndrome, PMS, menopause, the absence of periods, or patterns of abnormal bleeding. Discussing gender identity and sexual function touches a vital and multifaceted core of your patients' lives. A neutral, non-judgmental approach is critical for ensuring your patient's health and well-being. If the patient has concerns about her sexual activity or response, encourage her to describe them. Familiarize yourself with the latest screening guidelines from major organizations in order to counsel your female patients about screening for cervical and ovarian cancer, as well as sexually transmitted infections and HIV. You should also be well-versed in options for family planning, as well as hormone replacement therapy. By eliciting the patient's concerns before the examination, you prepare for an examination that is efficient and productive. Let's review the important anatomy of the external female genitalia. The external female genitalia, or vulva, includes the mons pubis, a hair-covered fat pad over the symphysis pubis, and the labia majora, rounded folds of adipose tissue. Medial to the labia majora are the labia minora, thinner pinkish-red folds that extend anteriorly to form the prepuce, and the clitoris, composed of erectile tissue. The vestibule is the boat-shaped fossa between the labia minora. In the posterior portion of the vestibule lies the introitus, or vaginal opening. The urethral meatus opens into the vestibule between the clitoris and the introitus. Inferior to the urethral meatus is the opening of the paraurethral or Skene's glands, which are not usually visible. The perineum refers to the area between the vaginal opening and the anus. Bartholin's glands lie lateral and somewhat posterior to the vaginal opening, but are not normally identified unless enlarged or infected. With the patient's health history in mind, and after good hand hygiene, you are ready for the physical examination. Prior to the examination, request that the patient empty her bladder. Plan to explain each step of the examination and be aware that the patient may be apprehensive. Before you start your examination, make sure the examination equipment is within easy reach, including a good light, a vaginal speculum of the appropriate size resting in a basin of warm water, materials for the Papa-Nicolau smears, bacteriologic cultures, or other diagnostic tests, water-soluble lubricant, cotton swabs, examining gloves, and tissues. During examinations of a sensitive nature, including those of male or female genitalia, it is important to observe the requirements of your facility pertaining to privacy and confidentiality. Therefore, clinicians should be assisted by a third party, such as a nurse or other health provider, whenever indicated. Drape the patient appropriately and assist her into the lithotomy position. Ask her to place first one heel into the footrest, then the other. She may be more comfortable with shoes or socks on than with bare feet. Her thighs should be flexed and abducted at the hips, and her arms should be placed at her sides or folded across her chest. Instruct the patient to move forward toward the end of the table until her buttocks extend slightly beyond its edge. Now arrange the drape so that it covers the patient's lower abdomen, thighs, and knees, and depress it between the patient's knees while still ensuring eye contact with the external genitalia. Adjust the light. As you proceed, explain each step of the procedure, move at a relaxed pace, and check the patient's facial expression for anxiety or discomfort. While seated comfortably, inspect the patient's external genitalia, including the mons pubis, labia, and perineum. To assess sexual maturity in an adolescent patient, note the distribution of pubic hair and rate it according to Tanner's stages. Tell the patient that you will be checking her inguinal lymph nodes and touching her external genitalia.
I'm going to be checking your inguinal lymph nodes, and then next you'll feel my hand at the opening of your vagina.
Separate the labia majora, if necessary, and inspect the labia minora, clitoris, urethral meatus, and vaginal opening. Note any inflammation, discharge, ulceration, swelling, or nodules. Palpate any lesions for consistency and tenderness. If you see swelling in the region of Bartholin's glands, or if there's a history of swelling, insert your index finger into the vaginal opening and place your thumb outside the labia majus. Palpate each side in turn for swelling or tenderness in the 4 o'clock and 8 o'clock positions. Before we begin examining the internal genitalia, anus, and rectum, let's look at the pertinent structures. The vagina is a musculomembranous tube that extends upward between the urethra and the rectum. The upper third lies on a horizontal plane and extending into the cup-shaped fornices on each side. The vagina ends at the cervix, which protrudes into the vaginal canal. Adjacent to the cervix are the anterior, posterior, and lateral portions of the fornix on each side. The vaginal surface of the cervix, the ectocervix, is seen easily with the help of a speculum. At its center is the round, oval, or slit-like depression called the external os of the cervix. The ectocervix is covered by the plushy red columnar epithelium and a shiny pink squamous epithelium. The squamo-columnar junction forms the boundary between these two types of epithelium. The squamo-columnar junction migrates toward the os, creating the transformation zone. This is the area at risk for later dysplasia, which is sampled by the pap smear. The uterus lies at a right angle to the vagina. It is a flattened, pear-shaped fibromuscular structure made up of the body, or corpus, and the cervix, which are joined together at the isthmus of the uterus. The fallopian tubes extend from the uterus, and their fringed tips curve toward the ovaries. The ovaries are almond-shaped structures that vary in size, but average about 3.5 centimeters in length. The tubes, ovaries, and their supporting structures are called the adnexa. Before beginning the internal examination, select a speculum of appropriate size that has been lubricated with warm water only. Do not use a gel lubricant because it may interfere with cultures and distort cells taken for pap smears. Let the patient know that you are about to insert the speculum and apply downward pressure.
I'm going to insert the speculum now, and you'll feel some pressure.
Lubricate one index finger with warm water and insert it gently into the vagina. Continue to enlarge the vaginal opening by placing 1 or 2 fingers at its lower margin and pressing down gently. This allows the muscles to relax and eases entry of the speculum. Locate the position of the firm, rounded cervical surfaces with your examining finger. This helps you to more accurately direct the speculum toward the cervix, which can vary in location in each patient. With your other hand, hold the closed speculum at an oblique angle and slide it past your fingers at a downward slope along the posterior vaginal wall, applying downward pressure to keep the vaginal introitus relaxed. Be careful not to pull on the pubic hair or pinch the labia with the speculum. Rotate the speculum to a horizontal position and withdraw your fingers. Carefully open the speculum, then rotate and adjust the speculum until it cups the cervix and brings it into full view. If the cervix does not easily come into view, withdraw the speculum slightly and reposition it at a different angle. When you can see the cervix fully, lock the speculum by adjusting the thumb screw and adjust the light so it illuminates the cervical os. Inspect the cervix and os. Note the color, position, and surface characteristics of the cervix, as well as any abnormalities, such as bleeding, ulcerations, masses, or nodules. Normal cervical discharge varies from clear to white and thin to thick. It is usually odorless. If colored or malodorous, obtain cultures if needed and examine the discharge microscopically. A yellowish discharge suggests mucopurulent cervicitis, commonly caused by Chlamydia trachomatis, Neisseria gonorrhoeae, or herpes simplex. Vaginal discharges are commonly caused by Candida, bacterial vaginosis, and Trichomonas vaginalis. Next, obtain specimens for a pap smear following current screening guidelines. To collect endocervical cells from non-pregnant women, insert a cervical broom into the cervical os. Rotate the tip of the broom 360 degrees in a clockwise direction. Then remove it and gently stroke both sides of the broom onto a glass slide and fix it by the method used by your clinical site. Or insert and swirl the broom in a liquid fixative, now in common use. The cervical broom allows you to obtain a single specimen containing both squamous and columnar epithelial cells. In place of the cervical broom, you may use a cervical scrape to obtain a specimen from the cervical os, making sure to include the transformation zone and the squamo-columnar junction. Then use the endocervical brush. Smear both specimens gently on a single glass slide. For pregnant women, a cotton tip applicator, moistened with saline, is advised in place of the broom or cervical brush. To inspect the vagina, unlock the speculum and withdraw it slowly, keeping it open with your thumb while you observe the vaginal mucosa. Note its color and any odor, masses, or ulcerations. Note any vaginal discharge that is unrelated to a physiologic or cervical discharge. A vaginal discharge may be evidence of cervicitis or vaginitis and warrants careful collection and the appropriate analysis. Check for bulging in the vaginal wall. Ask the woman to bear down to assess the location of vaginal wall relaxation or the degree of uterine prolapse. Close the speculum as it emerges from the introitus, avoiding excessive stretching or pinching of the mucosa. Now stand to perform a bimanual examination. Lubricate the index and middle fingers of your gloved hand.
Now you're going to feel me insert 2 fingers into your vagina.
And insert them into the vagina, exerting pressure posteriorly. Palpate the vaginal wall posteriorly, laterally, and anteriorly, including the urethra and bladder region. Note any nodularity or tenderness. Palpate the cervix, noting its position, size, shape, consistency, regularity, mobility, and tenderness. Normally, the cervix can be moved somewhat without pain. Palpate into the fornices around the cervix. Now, palpate the uterus by placing your other hand on the abdomen about midway between the umbilicus and symphysis pubis. When you elevate the cervix and uterus with your pelvic hand, press your abdominal hand in and down, trying to locate the uterus between your two hands. Note the size, shape, consistency, and mobility of the uterus. Identify any masses or tenderness. Cervical motion tenderness and adnexal tenderness suggest pelvic inflammatory disease, which requires cultures and prompt treatment. To palpate the right ovary, place your abdominal hand on the right lower quadrant and your intravaginal hand in the right lateral fornix. Press your abdominal hand in and down, trying to push the adnexal structures toward your pelvic hand. Try to identify the right ovary or any adnexal masses. If possible, note the size, shape, consistency, mobility, and tenderness of the ovary or adnexal mass. Repeat the bimanual examination on the left side. Normal ovaries may be mildly tender. They are usually palpable in slender, relaxed women, but are often difficult to feel in women who are obese or tense. Assess the pelvic floor muscles for strength and tenderness by withdrawing your examining fingers just clear of the cervix and spreading them against the vaginal wall.
Now I'd like you to squeeze my fingers as long and hard as you can.
Snug compression of your fingers that moves them upward and inward and that lasts for 3 seconds is full strength. If indicated, re-glove after this examination and lubricate your fingers to prepare for the rectovaginal examination. The primary purposes of the rectovaginal examination are to palpate the retroverted uterus, the uterosacral ligaments, cul-de-sac and adnexa, to screen for colorectal cancer in women 50 years or older, and to assess pelvic pathology.
Now I'm going to be doing the rectovaginal exam. I'll be placing one finger in your vagina and one finger in your rectum. What I'd like you to do is bear down. You might feel like you're having a bowel movement, but you won't.
As you ask the patient to bear down, introduce your index finger into the vagina and your middle finger into the rectum. Apply pressure against the anterior and lateral walls with the examining fingers and downward pressure with the hand on the abdomen. Check the rectal vault for masses. After the examination, wipe off the external genitalia and rectum, or offer the patient some tissues so she can do it herself. If a Hemoccult test is planned, you should change gloves to avoid contaminating fecal material with any blood provoked by the pap smear. Hernias occur in women, but are much less common than in men. Ask the woman to stand as you palpate in the labia majora and upward to just lateral to the pubic tubercles to assess for an indirect inguinal hernia. Remember that a clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care.
No inguinal adenopathy, external genitalia without erythema or lesions, vaginal mucosa pink.
After practice and further review of this video, make sure you have mastered the important learning objectives for examining the female genitalia.